So I'm going to talk about how best to treat decentration. So we can do wavefront guided ablation, which may be appropriate in some cases, or we can do topography-guided ablation. So I'll go over the wavefront guided ablation first. And these are two case reports of successful treatment of decentration with wavefront guided. And you can see here the difference between the pre-op aberration and the post-op. You can see that the wavefront was optimized, not flattened, but and you can see the asymmetry in the ablation profile. In this case, you can see that the topography show how decentered superiorly the optical zone was pre-op and nicely recentered post-op. Now the problem with using wavefront guided is that by definition when you measure wavefront, you're measuring data within the pupil and the wavefront is centered on the pupil center, on the entrance pupil center. And in some patients, the entrance pupil center is the same location as the corneal vertex, and that's a patient with a small angle kappa. But in some patients, the visual axis and the line of sight are not coincident. And in the corneal plane, you'll see the corneal vertex here in red, the entrance pupil center in blue, and in the corneal plane, we measure the pupil offset, the distance between these 2 points. And in this example, it's 0.75 millimeters. So that's a patient with a large angle kappa. And if we consider this example, it's a patient who was treated for hyperopic LASIK plus 4.25 minus 3. The LASIK was perfectly centered on the pupil. And if you look at the topography, you can see that it's quite well centered on the entrance pupil center, but it's obviously decentered with reference to the corneal vertex. Post-operatively, the patient was left with hyperopic astigmatism, and he was complaining of fogging, monocular diplopia, night vision complaint, and he was complaining of all the light going to one side, which is what we call significant subjective coma. And if you measure the wavefront centered on the pupil, you didn't see any coma. But obviously, if you had measured on the corneal vertex, you would have measured a large amount of coma. The surgeon decided to do a wavefront-guided retreatment for that patient, and there was no improvement in the symptoms. And you can see the topography after the wavefront-guided, which is almost unchanged compared to pre-operatively.
Worse.
Or worse. So this brings the question of where best to center the ablation. And we've recently published a paper in the Journal of Refractive Surgery. It was published last month, where we did a retrospective analysis of consecutive patients treated for hyperopic LASIK with a minimum sphere of 2.5 diopter. All patients were treated on the coaxially sighted corneal light reflex, which is the best approximation of the visual axis. And we had two groups of patients. The first group of patients had a small pupil offset, meaning that the corneal vertex and the pupil center were within 0.25 millimeter. And we had a second group of patients with a large pupil offset, more than 0.55 millimeters. So we had two discrete groups. And we compared the outcomes of the two groups. We looked at safety, accuracy, astigmatism, contrast sensitivity at 4 frequencies, night vision disturbances. And as you can see, there was no statistically significant difference between the two groups. They had the same outcomes. Now, if you look at corneal aberration, so the ablation was centered on the vertex, so we're looking at the aberration induced where the ablation was centered. And we induced the same amount of aberration in the two groups. There was no statistically significant difference between the small angle kappa group and the large angle kappa group. Now, if we look at the whole eye aberration, so measured with the wavefront centered on the pupil, did have a difference, as we expected, between the two groups, and we measured more aberration induction in the large angle kappa because the vertex was decentered with reference to the pupil center. So the fact that the results were similar between the small angle kappa and the large angle kappa group provided evidence against the entrance pupil centration and supports the centration on the corneal lag reflex. And this is another example supporting the corneal vertex centration, and this was a case report that we published in 2012 comparing topography-guided and wavefront guided. And this was a patient who presented, this is the topography, who had a decentered treatment superiorly. And this is the wavefront, and you can see the wavefront looks very symmetrical with mainly spherical aberration and very little coma. Why? Well, if you look at the eye image, and you can see that the pupil was decentered superiorly with reference to the vertex here. And if you look at the corneal wavefront centered on the vertex, you can see a large amount of coma, 1.93 micron of coma, compared to 0.4 if you measure with reference to the pupil center. So how can you treat this patient? Well, if you look at wavefront guided, this would be the ablation profile, which is symmetrical, mainly treating for spherical aberration. Or you can do a topography-guided ablation with a very asymmetrical ablation profile. So which profile do you think would be best? So we decided to treat with the topography-guided ablation. And these are the results. So you can see the topography post-operatively, which is nicely centered on the vertex. And you can see that the change in corneal topography matches the ablation profile very well. Now, if you look at the corneal wavefront pre-topography-guided and post-topography-guided, you can see that we've reduced the coma from almost 2 micron to 0.3 micron, and we've reduced the total amount of aberration in the eye. If you measure from the pupil, you don't really see any difference in coma. And this is just to show that the stromal change matches the ablation profile very well. And if you look at the two ablation profile, this shows that choosing topography-guided ablation was the right thing to do, and if you had decided to go for wavefront guided, you wouldn't have been able to treat the decentration in that case. This is another example, decentration after myopic ablation, and again we did topography-guided. Post-operatively, the topography is well-centered, and you can see that the change in corneal curvature matches the ablation pattern. And again, we decrease the amount of aberration relative to the corneal vertex. And this is just a video to show you the asymmetry of the ablation profile with all the ablation inferonasal in that eye. This is a second example of decentration after myopic ablation and after topography guided. Again, the post-topography was well centered, and the difference in corneal topography matched the ablation profile. And again, the corneal wavefront showed that the coma was reduced from almost 1 micron to 0.5 micron. And this is the third example, again, showing that the change in corneal curvature matched the ablation profile and we were successful in recentering the topography. Now, this is an example after hyperopic ablation. This patient was originally treated for +4 with a Bosch-Rhône laser with an optical zone of 6 mm. That's what the surgeon had aimed for. We measured the size of the optical zone looking at the Artemis epithelial map and the topography. And you can see that the achieved optical zone was actually only 5 mm. You can see on the orb scan and the Artemis map here. And we used topography-guided ablation to enlarge the zone and recenter. And this is the post-epithelial map after the surgery and the change. And you can see the thickening of the epithelium coincident with where we did most of the ablation here. So we successfully expanded the zone to 7 mm. And one last example, after RK, patient presented with decentration inferiorly. Post-operatively, the topography was well-centered, and again, the change in topography matched the ablation profile. And in that case, we reduced the coma from 3 micron pre-op to 0.42 post-op, and we reduced the amount of total aberration and improved the quality of the vision in that eye. So now I'm going to pass back to Professor Weinstein, who's going to talk to you about how to treat irregular astigmatism.